Yeah.
Okay, so wanted to talk a little bit about just what makes the pediatric history, and you guys are seeing this, I'm sure, in clinicals, but what makes the pediatric history different? And we talked a little bit about this before. Essentially, with children, they are their own little ecosystem. We need to look at their history. We need to look at their prenatal considerations, certainly any type of drug exposure in utero, and look at their growth and development patterns as well. So when you see a child and you see them for a new patient appointment, or the very first time you're seeing them, you're going to want to ask some really specific questions that you all would not be accustomed to asking in the adult population. So for example, I always ask the patients, okay, was your child born full term or were they premature? A lot of times they're not sure exactly what this means. So you may want to say, how many weeks pregnant were you when you delivered? And then the other thing I found, instead of asking if there's complications in the newborn period, if you ask them if the baby went home from the hospital with them, that's usually a very good indicator of how well the baby did right in that postnatal period. And then certainly we're going to ask about their development. Did they walk on time? Did they crawl on time? Did they talk on time? And see if there's been any type of intervention needed for that. Environmentally, it is definitely within our scope to find out who lives at home with the child, and to see, if both parents are involved. And there's a whole list of things that you'll see for growth and development that we'll need to ask as far as bonding. So we'll talk about those in a minute. So we kind of want to look at that whole family unit as a key component of the pediatric history. Now, last night I felt moved to add this cute little picture of my daughter's, and I apologize that it is a little bit misplaced and covering some of the words. So I will fix that and re-upload that. But that's Maris and Macy, my little twins, and as you can see, they think that they're adults, but certainly they are not just little adults. And so we're going to focus on what's different about pediatrics. One of the main things we're going to talk about is growth. And one of the most essential things that we do when children come in for their well child checks, and also just their episodic illnesses, is to check their weight. And I can't emphasize enough, in newborns, weight is probably the most essential vital sign. If a child is not gaining weight on the regular scale, or on the regular schedule that they should, then that can certainly be a red flag that there's some sort of underlying issue, such as a cardiac defect, or some sort of metabolic abnormality, chromosomal abnormality. And really the way that we are going to know that, the only way sometimes we're going to know that, is in those first month or two appointments, and looking closely at if they're gaining their expected amount of weight. So can't emphasize that enough. And when we talk about nutrition, we're going to, and also just infant growth and development, one of the things you're going to want to put to memory is that normal weight gain that we expect in newborns. And you'll see your preceptors looking closely to see if that infant is gaining 1 ounce per day. So for the first 6 to 8 weeks, they usually will gain approximately 1 ounce per day. And so that puts them at approximately 7 to 8 ounces per week. And so we know then that a normal healthy newborn should be gaining about 1/2 pound every week. And so that's one of the differences that you'll see in the clinical setting that focus on weight gain. The other thing I wanted to point out is that babies grow cephalocaudally. That means from head to toe. And so what you'll see is that babies get those big big, beautiful heads, and then their bodies will grow. So their head grows first, and then their bodies will grow in length. And they also grow from the center outward. And so you'll see that in that picture. Another key difference in children and pediatric assessment is the skin. And especially in that newborn period, infants have much less subcutaneous fat, and so they are much more likely to get hypothermia. When they start to lose heat, they also start burning some of their brown fat, which will then lead to hypoglycemia. And so this is the reason why we always, keep our newborns bundled up, and we keep their heads covered, because the biggest component of their body surface area is actually on their head and on their scalp. And so by keeping their body surface covered, we keep a lot of that heat in and prevent heat loss. So just one of the things to remember in general is that newborns, just like elderly, have a thinner component to their skin. And so they also absorb things, medications, anything that's put on topically, they're going to absorb those quicker and more extensively than adults. And we'll talk more about body surface area and measuring body surface area, but just as a general consideration, children have more of a body surface area than adults. So what that means is they have more skin to both absorb medications and also more skin surface to lose heat easily. Another difference is their hydration component. So a body of a baby is about 78% water, and that's compared to about 55 to 60% in adults. So we know that when we are, because we are so much of our plasma and our just we're composed of so much water, that when we start to lose that water, then we start to have metabolic changes as we become dehydrated. So the fact that a baby is so much more heavily comprised of water of their total weight, then they are much easier and much quicker to be affected by changes in their hydration status. And this goes both ways. So we know that infants and young children are easily dehydrated for the reasons we talked about with their body surface area. Also, their metabolic rate is higher, but they are also very sensitive to overhydration. And in fact, I've had a patient who lost a sibling before in the NICU, and it was a medication error, but it was actually the error was just the IV fluids. And what would have been a drop in the bucket for an adult to have, to compensate for that error, the infant just could not. It was a neonate, and they could not compensate for that IV rate error. They became overhydrated too quickly. So, hydration is key, and children are not able to tell us often that they feel, dehydrated, or, that they won't express that need for thirst. And if they're not feeling good and they're running fevers, and certainly that will increase their fluid loss and metabolic rate, they're just very susceptible to dehydration. Another difference is we see the lymph nodes in the lymphatic system in children. And when you're in clinicals, you will see in your school-age children sometimes very large tonsils. This is a key difference in the pediatric population. Usually after 6, 7, 8, 9 years of age, the tonsils will start to atrophy and start to shrink. So adults, if we still have our tonsils, usually our tonsils are much smaller size, may not even really be visible. But a normal finding in that 6, 7, 8-year-old child are sometimes +3 tonsils. Of course, we wouldn't expect them to be red or have exudate or anything like that, but just large tonsils. And if you remember, tonsils are actually part of our lymph system. So the lymph nodes and the lymphatic system in general is just a little bit more active and palpable and visible in children during that time frame. So because their skin is, usually they don't have as much subcutaneous fat, when you're palpating lymph nodes in their neck, often you're going to feel what we call shoddy, just kind of some leftover normal lymph nodes, especially in the anterior cervical area. So, anytime that we hear the word or feel enlarged lymph nodes, we start to get concerned. But certainly in healthy children, that can be a normal finding. Especially if they've had a lot of infection, whether it be ear infections or tonsillitis, strep throat, you're going to feel some leftover lymph nodes, which we would expect to be bilateral, and we would expect those to be non-tender and usually just about pea to marble size. So we would still be concerned and want to follow up if you felt like a unilateral hard lymph node, but just those little, I usually grade them as pea to marble size lymph nodes in the neck. Those are usually normal findings, and a lot of times children will come in presenting just with a concern of lymph nodes because it tends to worry parents. The other, another key component to the pediatric assessment that's different in adults is the infant and young child's skull. So we remember from Women's Health that during the delivery period, the sutures on the infant skull will overlap, and they're movable. And that's, just the general mechanism for the baby to come through a vaginal delivery. And so certainly those skull bones are going to be separated, and they're going to, in a normal finding, be somewhat mobile until 12 to 15 months of age. So that's one of those key time periods that you may want to commit to memory. When should those sutures fuse together and we not feel that quote unquote soft spot? And that would be by the 12 to 15 month period, and hopefully not sooner. So you should feel a nice soft anterior fontanelle until about their first birthday or so. However, if it closes before that and we really can't feel one at all, we have to kind of look further into that, because the skull bones are made and designed to be mobile and to be able to expand during that first year of life. There is such rapid brain growth. And so what happens if there's a premature closure of the anterior fontanelle, then the brain becomes compressed. And so we can actually see significant developmental delays that are associated with with premature closing of the anterior fontanelle. And that's called craniosynostosis, which you don't need to commit that to memory at this time. But just know when we're looking at the infant's head circumference, that is really one of the key things that we're measuring, that making sure that the head is growing and expanding at a normal pace. So we don't want it to grow too quickly, because that leads us to be concerned about like hydrocephalus, which is fluid accumulation in the brain. And we don't want it to grow too slowly, which would be microcephaly, because then we'd be concerned about premature fusing of those sutures. And so those are just two of the major components that we're looking at and checking for microcephaly or macrocephaly with the head. Now you will see a lot of different shapes of heads in infants. And, certainly I remind parents that if we all were walking around where we could just see our skull, we all wear different hat sizes and we have different shapes to our head. And a lot of that is just normal variation. So we just want to get accustomed to really looking at head shape and head circumference and getting a feel for what's normal and what's not normal. And then newborn reflexes, I know you probably have looked a little bit at those before in your assessment classes. What I wanted to point out is that a key component to the newborn and the 2-month and 4-month well child checks are to see if those newborn reflexes are present when they're supposed to be present, and then also that they disappear when they're supposed to disappear. And so this is just kind of a review of the different reflexes, and I think this is one of the most enjoyable parts of a newborn exam, when you can kind of go through and show the parents of the newborn all these different reflexes and say, okay, well, this is the palmar reflex, and this is the Babinski, and this is the plantar, and just show them what the natural normal response is to what you're doing during your assessment. So just wanted to point out that these are all normal, but they do disappear, and we want them to disappear because that's a sign of an intact neurologic system. Okay, and wanted to point out a couple things about vision. Another component of all of the well child exams, once children are old enough to start using the Snellen eye chart, usually about the kindergarten age, we need to be really looking at the visual acuity, because when children start school, you can see here on this chart, at 5 years of age, their vision should be almost normal, okay? So 20/30, and we know 20/20 is a normal vision. Again, this is one of those things that you may want to commit to memory. When should a child reach normal 20/20 vision? And that's going to be right between that 6 to 8 year mark. So really, first, second grade, they should have 20/20 vision. Now, what we do in the during the well child exams is really just a pretty rudimentary vision screen. And so all children, we're just looking at their ability to see the chalkboard, basically, and their up close vision and ability to see the letters in their book. But certainly they still need to go, usually at 7 years of age is when it's recommended. So right there between that 6 to 8 year mark, that's when they need to go and have a formal eye exam with an optometrist, and that way they can have their eyes dilated and look and check for astigmatism and different things like that. We just want to make sure that parents understand that we're just doing a very basic vision screen. Okay, and then thinking about the ears, this is certainly a difference in pediatrics than in adult populations. This is what sets, these differences are what set up children for having so many ear infections. You know, as adults, we do on occasion get an ear infection after perhaps a bad upper respiratory infection or sinusitis. But the way that children's ears are anatomically formed just makes them naturally susceptible to infection. So the first issue with the ears is that the actual ear canal is shorter and it's curvier. And so what you'll find in clinicals when you guys are practicing, and I can't encourage you enough to look in every ear that you get an opportunity to in the clinical setting. And when you can't see the eardrum, you just tell your preceptor, I'm sorry, I just can't see that. This is a very much acquired, practiced skill to see ears in general, but then also when you have a squirmy, 2-year-old and you're trying to see the tympanic membrane, it's not an easy task. So the fact that their ear canal is curvier means that a lot of times you're just going to have to take that otoscope and, kind of move it around a little bit, pulling the pinna in different directions until you're able to visualize the tympanic membrane. But the key component that makes children more susceptible to infection is that second bullet point, that the eustachian tube is wider, shorter, and straighter. And the straighter component is what makes it more prone to the backflow of sinus drainage and normal middle ear fluid to accumulate behind the eardrum. So essentially every time that, and you can see that eustachian tube there, the picture on the bottom, you can see how that eustachian tube is, on the bottom is the adult and on the top is a child. You can see the eustachian tube is just more horizontal. And so that normal fluid that's made in your inner ear and middle ear does not drain as well. And then certainly when children get viral infections, and just as a case in point, most children, the first year of life that they're exposed to other children, be it kindergarten or daycare or preschool, they are going to average 6 viral infections that first year. It's just a very basic average that you can tell parents to expect. Why are they sick? They're sick ever since they started daycare. Well, yes, because they're probably going to pick up every virus that they have not been exposed to. So what happens is when they get those upper respiratory viral infections, the nasopharynx becomes red, swollen, inflamed. Their eustachian tubes will become inflamed. And then that fluid is even more stationary and just sits behind the tympanic membrane there, and then becomes infected because it's a perfect place for bacteria to grow. And any bacteria from your sinuses, from your nose, from the child's nose, is going to migrate up into that fluid and set up residence there and grow. And so this is why a lot of times children will have to get pressure equalization tubes, because just by adding a little a hole in the eardrum, it helps equalize that pressure that accumulates behind the eardrum, and that hole actually makes the fluid drain down into the sinuses easier. So it's not that the fluid drains out of the tube, it's that it actually facilitates drainage downward by equalizing that pressure. So that's just another anatomical difference to children. And feel free to stop me at any time if you have questions. Children's sinuses, a lot of times we diagnose children with sinusitis, but honestly and truly, they do not have sinuses, and they're like the frontal sinuses, the ones that we, typically see in adults as problematic, until they're 7 or 8 years of age. So your sinuses start as little tiny holes in your head and then get larger as the skull grows. So, you know, just keeping that in consideration that most of the time in children, we see upper respiratory infections and we see ear infections, but an actual sinusitis, that is inflammation and infection in the frontal sinuses, is rare. And so that's just another difference to take into consideration. And then, of course, one really important difference to consider in pediatric assessment is the pediatric airway. Babies are obligatory nose breathers. And what that means is that they have to breathe, they have to have their nasal passages clear in order to breathe. When we get, as adults, when we get an upper respiratory infection or allergies bothering us and our nose is occluded from drainage or inflammation, then we walk around kind of breathing through our mouth all day and trying to coordinate breathing and talking through our mouth, and we're able to drink. But babies cannot do that. We have to keep their little noses suctioned out. Often we have to use saline to thin that mucus and get a lot of that drainage out, or they really will not be able to breathe. And they certainly will not be able to take a bottle or breast because they can't coordinate the breathing and drinking at the same time. And I've seen pulse oxygen saturation levels come up from the low 90s up to, normal 95, 96, 97, just by sucking out the nose of a sick newborn or a sick infant. A lot of times with RSV, that's the key with respiratory syncytial virus, and we'll talk about that, but that occluded the occluded nares with all that mucus that comes from the virus, that's really what's so problematic for the babies, because they will get dehydrated because they just they can't take a bottle or breast because they can't breathe through their nose. You'll also notice that they are raising their belly up and down, their abdominal belly breathers, and so we use our chest muscles to breathe, whereas infants and young children use their abdominal muscles. And so when they are in any kind of respiratory distress, you will really see them tugging in and using those accessory abdominal muscles. And that's just a normal finding in infants, but so that is another reason why we always want to have an undressed exam. And I can't emphasize enough that you have to look as well as listen when you're doing the airway assessment. Also, we see nasal grunting and we have grunting and nasal flaring when young children are in distress. And so we're going to want to be looking at the respiratory effort that way. Another thing I wanted to mention is the trachea. I had a child in clinic this week with tracheomalacia, which is tracheomalacia is basically soft cartilage, and an infant's cartilage over the trachea is more elastic and easier to collapse on a normal basis. But then there are some newborns who are quote unquote noisy breathers, and what you'll hear is that ever since they were born they just are really loud breathers, and so this gets misdiagnosed often as wheezing or pneumonia, different things like that. But what it is that cartilage that covers the trachea can be really elastic and collapsible in just a small percentage of infants. And they will actually suck when they're breathing in, that cartilage will kind of collapse and partially occlude the airway. And so what you hear is stridor. And that's that upper airway noise you hear, like with croup and things. But so the trachea, again, this is why children are more likely to really get into respiratory distress when they get some of the illnesses that to us are just more like a cold. They can, with bronchiolitis and things, can get into really significant respiratory distress. And then one other point is that I think I mentioned before that infants in general have a higher metabolic rate, and so they require more oxygen. And so their SATs will drop relatively quickly, and they can wear out or wear down, as you may say, quickly, just because they really run out of energy and they run out. And so what you'll see is they'll be tachypnic, maybe while they're struggling and are, you know, in distress, and then they just kind of slow down. And so that is a very ominous sign when we go from being tachypnic and out without any intervention. You'll just see them, their respiratory rate start to go down and down, and that's because they're just wearing out and they're getting hypoxic. So what is a normal respiratory rate for children? And I wanted to point out that it's opposite from blood pressure. So newborns, as well, the younger they are, the faster they breathe. So a normal respiratory rate in newborns is 30 to 80, and truly some things will say up to 100. You know, at the very newborn period, they're 100, 120, and that's a normal finding. And then as they grow and develop, their normal respiratory rate is going to slow down. So when you're doing your 3-year-old checkup, it's good to know that, you know, 29, 27, 28, these are normal respiratory rates for a healthy 3-year-old. Okay, another key difference is that an infant's chest is round and about the same circumference as the head. And certainly adults' chest and head, hopefully, are not the same size. And so that is a key difference in infant growth. And this is the way, this is a normal finding until about 2 years of age. And then they start looking more adult-like in appearance. And another key difference is the chest wall is thinner. And so the pericardium is just very close to the surface. And so when we're listening with our stethoscope, we're much more likely to hear, it's just easier to hear their heart sounds and lung sounds. And so it's, you know, when I listen to adults after listening to children all the time, I feel like I can't really hear much of anything. And that's just because you can really hear any wheezing or rhonchi, heart murmurs, things like that in children because of those anatomical differences. So now on the other hand of that, and we'll talk about that, murmurs sometimes, you know, we get concerned, but if there's not other findings going along with those murmurs, we're just hearing sometimes the normal function and blood flow through the heart. And we'll talk more about that, but just kind of keep in mind that the reason you're hearing all of those sounds so well is because the chest wall is thin, and the heart and pericardium is just really close to your stethoscope. Another difference that concerns people if they haven't listened to a lot of pediatric patients, you'll notice a sinus arrhythmia. And so when they take a breath in during inspiration, the heart rate will go up and then it slows down. So what happens is it stresses providers out that aren't used to that, because it sounds like an irregular heart rate. And so this is normal. So this is a normal finding to have a sinus arrhythmia. And when they take a big breath in, you'll hear their heart rate go up, and then they'll breathe out and it's slower. So don't worry about that or be concerned. I talked a little bit about murmurs, and we'll talk more about that. Just know that they can be normal or they can be abnormal. And then bradycardia is not a usual finding in children. And it's usually the result of hypoxia. So this is a different when we think about, I know all of you all are CPR certified, and some are probably PALS or NRP certified, but usually the number one cause of cardiac arrest in children is usually, it's almost always secondary to a hypoxia of some sort. And so that's different from adults. So there are some underlying cardiac conditions that will certainly cause be the problem with a cardiac arrest, that will be the main source. But the majority of the time it is from a drowning or some sort of a hypoxic episode that leaves them in distress. And then normal heart rate is fast at birth and slows down by the time they're about 10 years of age. So another thing to notice is that when the younger they are, the more variable their heart rates are. They can get very, when they have a fever, when they are upset, when they're stressed because you're trying to look in their ears, their heart rate may go up considerably. Or if they've been, running around out in the parking lot and then they come in and you are looking at their vital signs, they may be tachycardic. That can be just normal, and you can repeat that after they calm down. Another consideration that's different is the blood pressure, and like I said, it starts low and rises up, and so that is opposite of the heart rate. And after a year of age, you can calculate the expected blood pressure by taking the child's age, multiplying it times 2, and then adding 80 to it. And so that's just kind of an average or expected, like what should a 10-year-old's blood pressure be? And that's a way to find that out. Okay. The heart and circulation, we're not used to seeing cyanosis in our patients, right? In adults, we kind of panic when we see cyanosis of any kind. But I wanted to point out that cyanosis of the hands and the feet in newborns is very common. And this is essentially from a lack of neurological regulation of their capillaries. And so basically they're not as neurologically mature enough to coordinate the vasodilation and constriction that we need. And so when their little feet get cold and their hands get cold, often they'll turn a purplish blue. And so we just need to, if you warm them up, kind of put your hand around their feet, you'll see that it'll quickly pinken back up. And so sometimes this is really pronounced in the newborn period. And so you just want to remember that that's a normal finding, because certainly that concerns parents as well if their baby's feet are turning blue. In consideration of the infant's abdomen, we expect that little pot-bellied appearance in toddlers. So they have a normal kyphosis there when you're looking at them. And then after age 5, they start to look more adult-like in appearance. But we expect the toddler, the infant toddler, and young child to have that kind of pot belly. And it's just because that musculature, their abdominal muscles are not fully developed yet. Okay. The liver and spleen are larger, and you may feel a spleen when you're palpating the abdomen, just the tip of a spleen. That can be in really thin children. Sometimes you're able to feel that, whereas in adults, usually we don't. There are also, in time, certain illnesses such as mono, the liver can become enlarged, spleen can become enlarged, and they have a large amount of blood supply to them. And so they are at a risk factor for rupturing too when they become large and inflamed. And then I just wanted to point out about muscles and bones in children. You know, during that rapid period of growth, the connective tissue are actually stronger than the bones until adolescence. So what this means is that they are much more likely to have musculoskeletal injuries. And their long bones and joints are more likely to result in fractures than in sprains. So we kind of have a weak, just in general, weaker bone structure and bony matrix until they get to adolescence. So more likely to have fractures. And then another thing is that rapid growth will result in a decreased strength and flexibility. And so when we don't have as much flexibility, we're able, it just sets us up for injury as well. And so this is just a normal finding to enable, help the body support itself during that rapid growth period. And then the bones will become the stronger component. Another normal finding that's different in pediatrics is this knocked knee appearance, and this is very normal until 18 months of age, and also that flat-footedness. And so parents will get very concerned about an abnormal gait, and what I usually reassure them is until 3 years of age, most orthopedic doctors won't even really see a child unless there's an obvious deformity, because it takes about 3 years for children to really learn how to walk and support themselves, and they have some pretty abnormal appearing gaits as they learn to toddle around. So this knocked knee appearance is normal, so we don't have to be too concerned about that unless there's a major deformity. And then the spine of the baby is kind of a concave, curved spine. And then as they become upright and are toddlers, then they go the other way and they have that lumbar curve. And then adolescents, as they grow, they may have a slight kyphosis where they're kind of a slump shoulder, and you almost wonder if they have a scoliosis. A lot of that is just postural, and we have to remind them to, work on posture and make sure that they are being screened, that we're screening them for scoliosis to make sure that that's not a problem. But almost all of the ones that I see that appear to have some issues, once you actually do a scoliosis screen, it's usually a positional thing where they're just kind of hunched over. And then the other thing I wanted to mention is pain. It used to be hypothesized that infants did not feel pain. This is absolutely not the case. They used to not even use any kind of pain medications or numbing or anything in neonates, and now they do. But just wanted to point out that in newborns, they do not demonstrate signs of and symptoms of pain like adults. So a lot of times it will change their respiratory rate. They'll breathe real shallow. They'll have some different facial expressions. And sometimes they're just really stiff if they're hurting. And this is not just for infants, but for children as well. And I remember when my son got his tonsils out when he was like 6, the only time we could tell that he was really starting to hurt and needed his pain medication, he wouldn't tell us that he was hurting because he didn't like the taste of the medicine. But he would get to where he was just kind of really stiff while he was watching cartoons and wouldn't move, didn't want to change positions at all. And so you have to watch for those key signs to know if a child is really in pain, because they often do not tell you and they don't localize it. So in summary, here is a picture of of an infant, and you can see some of the differences that we have talked about. This might be a good one just to kind of have a snapshot of. It has a lot of the components of what we've gone over here. And now we can